So I'm going to start the lecture now. Okay. So this one, there may be some repetition because lecture you had this morning about telemedicine is also part of the HI in Malaysia. So since it is already covered in great detail by Prof. Mariati, I'm just going to gloss over that part. Okay. Okay. So let's start with the health informatics in Malaysia. Okay. Okay. This one you already had on the first day of the lecture. This one you already had on the first day of lecture. These terms is a bit peculiar because so using the term health information system or hospital information system, they call it health informatics because they want it to be a larger thing. So the larger thing. So when you have anything or everything that is involved in patient data, in medical collection data, collection of medical data, so they put it under health informatics or under medical informatics. The textbook is entitled Medical Informatics. Okay? So anything that is involved with collection of data between the doctor and the patient, and converting of the knowledge, the data into knowledge, that is under the health informatics. So you already covered this on the first day. Okay. So since we're covering Malaysia, we're just covering what we have among these countries, in this country, this country. So I think you all know where Malaysia is. No need for me to repeat. Okay. Of course, Sabah and Sarawak is not that close to Semenanjung. Okay, let's talk about the healthcare facilities. Okay, how many healthcare facilities we have in Malaysia? So we have both government and private. So I think we already covered that day a bit. Okay, and the Malaysian healthcare system, we especially in the government side, we practice what it is called as the two-tier system. We practice what is called as a two-tier system. So this two-tier system consists of the rural health clinics, rural health clinics, or also known nowadays as community clinics. Last time, the rural health clinics were maintained by Jururawat Desa, rural nurses last time. But nowadays, everything has been upgraded to have at least a staff nurse or a public health nurse running the community clinic. Then for every 4 rural health clinics, there is 1 public health clinic. The Malay word for it is klinik kesihatan. Last time when we had the 3-tier system, we had the Pusat Kesihatan Kecil, PKK, and we have the Pusat Kesihatan Besar, PKBs. When we migrate from the 3-tier to become the 2-tier, so all the klinik kesihatan are just known as klinik kesihatan. Okay, so no more Pusat Kesihatan Besar or Pusat Kesihatan Kecil, and they take care of this rural health clinic. So last time when I was in charge of klinik kesihatan Rembau, I have 4 clinics under me. So what I do, I rotate among these 4 clinics once a week, every week. So especially the distant one, and I tend to go there on Thursday, every Thursday afternoon. On Friday, I have to go to the juvenile center. The juvenile center. So I'm not going to cover that. I may end up talking about politics about that, but let's not cover that. So Whenever I have cases that I cannot manage, which require referral, I will refer them either to the district clinic or to the general hospital. Sorry, the district hospital or general hospital. The district hospital is Tampin, and we have general hospital in Seremban. But I've been told by my district medical officer of health not to refer cases to Tampin because they don't have specialists. Any cases that I cannot manage, I should refer to Seremban because Seremban has got the specialist. That is our system in Malaysia. Okay, so and because of that, we have a lot of health facilities, like rural health clinics and health clinics, or in the Malay word is klinik kesihatan, and they are in the thousands. So we have the rural health clinics, 1,000 of them, and this one for the health clinic is about 1,085, I think. I cannot really see the slides. Hospitals, we have very few. We have only about 135. So this data is from the year 2015. Data is from the year 2015. So I did look around. I did find some of the much more recent data set. 2017, we have 144 hospitals, 135 of them are our general hospitals, and 9 of them are our specialist medical institutions. This one, our Institute Kesihatan Negara, Institute Kanser Negara, we have Institute Perubatan Respiratory, so which is National Institute of Respiratory Medicine and National Institute of Cancer. Okay, so those are our special medical institution. Even in Johor, I think they have 2. One of them is just meant for cancers. There are other hospitals which is not under Ministry of Health, but instead they are under MOHE. There are 4 under MOHE, and there are 5 under the Department of Defense, Ministry of Defense. So just take note. So you have the separation under the health and the hospital. So the health has got their own structure. The hospital has got their own structure. So based on that, when we look at the progress, we have to look at number of adoption of the health informatics by the number of facilities compared to the total number. I've shown you just now, we got 3,000 clinics, 2,000 are rural, 1,000 are yes, Novena. Anything?
Oh, sorry, I forgot to mute.
I thought you want to ask a question. Okay. So whenever we talk about this, we must remember total hospital under the Ministry of Health, we got 144. Okay. So total of clinics, we have 3,000. 2,000 rural health clinics, 1,000 our normal clinics. Even the 2019 data, based on the 2018 data, not much has changed. The number of clinics are the same, 144. Sorry, number of hospitals are the same at 144. The number of health clinics is now at 1,090. And the community, the rural health clinics, there are 1,791. Okay. So these are the data that we have for the. How about the private side? Private side, we have hospitals numbering about 219 nowadays. We have numbering about 219. And the distribution of the private hospitals, are very much focused at urban areas. So where are most of the hospitals are? They are in Selangor. Okay. So if you look in Selangor, our number of private hospitals is 56. For Kuala Lumpur, the small Kuala Lumpur, they have 41. The next highest is Penang with 20 private hospitals. So it is very much a reflection of their ability to pay. Sorry. The other large one is Johor. The other large one is Johor with 32. So Johor also is a large state, and they have 32 private hospitals there, compared to the rest, where they have less money to spend on health. Okay. For example, Sabah has only 4 because they can't afford to pay for private services in the hospitals. If you look, the worst is Kelantan, only 3. Okay. So not much chance of changing work if you're working in the private hospital in Kelantan. Okay. So when we talk about all this, just take note of the number. So that is we're talking about hospitals. How about clinics? They say that there are a total of 7,879 clinics now in early this year. Early in 2020. Okay. 7,879. I think it's not. I think this year lah. Okay. So just imagine the number of private clinics are a lot more than the number of government clinics. So government clinics, if you just count the one with the doctors, there's only 1,000. But the private clinics, there are almost 8,000. 8,000. And they are everywhere. Every single corner, every single road, they can find 1 or 2 clinics. So, okay, so there are about 8,000 nowadays. Okay, so that is the story about the road. Okay, that is the story about the story about the healthcare facilities country. So let's relate that with the hospital, the health informatics in Malaysia. I don't know anybody recall this. Way back in the 1990s, before I graduated in 1992, there was a big hoo-ha in Hospital Kuala Lumpur, where the director of the hospital spent million. I think what came out with in the accountant general report was $1 million lah. I can't remember exactly. Long ago. Okay, I did try to search for that information. Cannot find. So way back in the 1990s, the Hospital Kuala Lumpur, the director was ambitious. They wanted to improve working conditions in HKL. They spent $1 million, computerized everything. And after 2 years, nothing came out of it, which is very sad. It is very sad. But you have to understand, when this guy was doing that, we don't have internet. We don't have Wi-Fi. We don't have. So even to have internet, you have to pull the wire yourself. I still remember when I joined UKM in 1996, I have to pull the internet wire through the ceiling at the computer room so that we can have internet access. So when this guy ventured into this computerization, it was well before what he wishes to do is possible. And because he spent about R1 million, at the time quite big, the pay of a doctor in that time is 800 ringgit a month. 800, yeah, so very few. So there was a white paper. So after that, everything that we do, we always look back with fear, worried that we are going to be the next white paper presented in the parliament. Okay, so that's why those who know tend to play safe, because unless you can deliver what was promised, you will end up being the next person being slaughtered in the parliament. Okay? So when I joined service in 1992, it was towards the end of that fiasco in HKL. So I joined Jabatan Kesihatan Negeri Sembilan, the State Health Department of Negeri Sembilan in 1996, 1997. Sorry. Now I'm getting confused. I joined them in the year 1993, 94. Then 94 and 95, I was involved in this information system strategic plan. This also was another humongous idea, another big idea. They want to computerize everything. The state of Negeri Sembilan is supposed to be the pilot where all the clinics are going to be wired to one another. So this information system strategic plan, which was mooted in 1995, finalized in 1996. Suddenly, when Mahathir has got his idea wanting to have the multimedia super corridor in 1997, the information system strategic plan was transformed to become the telemedicine blueprint. Was transformed to become the telemedicine blueprint. Okay. During that time also, in 1995, there were plans for a total hospital information system, Hospital Selayang. I know because I had to attend the meeting on behalf of my state director, which is messy. So I had to travel from far to attend the meeting. And in 1997, you had the MSc from Mahathir for telemedicine blueprint. Then you already had the selection this morning, so you already heard about the various incarnation of the telehealth project. Year 2000, different flagship project. 2004, different flagship. 2007, also different flagship. Okay. You know my views about that, so I won't elaborate. You all decide whether it's success or failures. And all of you are too young to remember all this. Okay, because this one was maybe when you were very, very young. So the success story, Hospital Selayang, was launched in 2001. It was mooted as a success story everywhere, claiming that this is THIS. And the word THIS stands for the word Total Hospital Information System. Okay. And because they claim it is a success, this was expanded to 13 hospitals in the year 2006. In 2014, it was expanded to include 21 hospitals. And now we have, in 2018, the MyHDW, which is the SMRP and the PRIS. Okay? Sistem Maklumat Rawatan Pesakit, or Patient Treatment Information System, and the Patient Record Information System. Sorry, Patient Registry Information System. So PRIS and the SMRP. PRIS is more like a registry for cases for diseases like cancer, diabetes, hypertension, and so forth, or cardiac diseases. SMRP is to record the encounters of people coming to seek treatment at any of the healthcare facilities. Okay, so this in summary is what we had. Okay, so let's talk about the THIS. Have you had this one already? All the different incarnation of THIS? Did Mariati cover this?
No, doctor.
Oh, okay. Thank you. Thank you, Eng. At least I know Eng is around. All right. Okay. So this THIS is, they say they have basic, which is BHIS, intermediate, which is IHIS, and they have total, which is a THIS. I still remember they claim that the THIS they have in Selayang is better than what is being implemented in USA. Because they say in USA, because every single facility is owned by different person, different entity, they cannot have one single information system. And so they claim, because in Malaysia, everything in the hospital of Selayang is under the same management. What they have is the full implementation of PHIS. So what is the difference in BHIS, IHIS, and THIS? So for BHIS, it's very basic. They just have records of the patient. They just have records of the patient management system. So they can have admission, discharge, transfer, or they can have a recording of the patient's encounter. The clinical information system are not really like what you had the lecture of CDSS. The clinical information system is more of a record of every single encounter the patient had with the aforementioned healthcare facility. If they come hospital, what is the date of admission, that is discharge, what is the records, and so forth. So IHIS, they have addition of lab and pharmacy. They have addition of the lab and pharmacy system. So that is IHIS. So lab, it makes tracing of results easier. Pharmacy, it makes dispensing of drugs easier. Okay. So for total hospital information system, THIS, they claim to have everything, including radiology. As we had the lectures before, radiology is the most expensive investment because you need specialized equipment for all this. Okay, so they also cover administration, financial, inventory, and personal information. Okay, that is THIS. Okay. So we already said that it is being implemented. So this is implemented where? This is where they were implemented. Do not ask me where they are. Okay. I did try to look for hospital Kuala Batas. I couldn't find. I think it is hospital Kepala Batas. But there's no Kuala Batas. Okay, there's no Kuala Batas. They have Hospital Setiu in Terengganu, Hospital Pekan, Najib's area, Hospital Pitas in Sabah, Sabah, Sarawak. They have Hospital Kuala Penyu and Hospital Kunak. If you look here, the name of all these hospitals are newly built hospital that were recently built. For intermediate system, they have the Hospital Keningau, Hospital Hadatu. These are also hospital that was recently finished. Okay. So for the total hospital information system, we have Putrajaya. Of course, the flagship is Layang. So that there's Putrajaya. We have Serdang, Pandan, Ampang, Sungai Buloh, and the other two new hospital, like Hospital Alostar, they shifted from the old hospital to a new one. Then they have Hospital Sungai Petani. So that is also a new hospital. So those are the hospital that is implementing PHIS, IHIS, and PHIS. After this, everything about the My HDW that we covered that day together on Thursday, on Wednesday. I don't feel like repeating the whole thing about the PRIS, the SMRT. We already covered that. Okay. So that is the history about the public sector. The history of the, okay, just to put everything in context, we have only new hospital, you know. Oh, not this one. We have only 21 hospitals. The 21 hospital, total hospital that we have is 144. So 21 divided by 144. So roughly about 14%, yeah, of the hospitals are computerized. So it is a small number. It is a very small number. But I did have the look at the report. The report says 15%. Because they did not divide by 144, they divide by 135. Okay. So 21 divided by 135. They get 15.56% of the hospitals in Malaysia are computerized. The rest are not. Why they are not expanding it further? The biggest issue is cost. Biggest issue is Arati said you all wants to ask question about what? Malaysian patient safety and health, safety and quality. Okay. Any question about the history of HI in Malaysia? I cannot cover about the clinics because clinics, as Eng mentioned that day, there are many different software. Some of my friends are selling these softwares and they use it to run their respective chains and branches of clinics. KPJ has got their own system. Pantai has got their own system. So whenever they build a new hospital, they also transfer the expertise and adopt the hospital system for the respective places. So it is very hard for me to cover that. And you already saw the number of hospitals around 200 plus, 219. And everyone got their own separate system. So, but most of the private hospitals, they focus the computerization is on the billing part because they want to capture all the costs. So everything that was ordered for places like Tawakal, because they were using a hybrid system, paper-based and computerized. So every time there is an order, the order is written in duplicates or triplicates. So the main one will go to the lab, and the lab will do all the tests. But the other copy will go down to billing, and billing will put this into the patient's record. So all of this hospital system for the private one, it tend to be focused at charging the patient accordingly. Charging the patient accordingly. Jadi, who's working in hospital, Melaka? Novena?
Long time ago, doctor. 2013, I was there.
You know how they charge their patient?
I didn't.
So how public hospital charge their patient is by counting the number of tests done for the patient per visit. So they will open up the file, they will go through all the blood tests, and they count the number of days the patient has been in the ward because the charge is by the day, and the charges for the respective X-ray and all the different blood tests. When I was admitted for a snake bite, I was discharged before the results for the blood count came back. So I was discharged with charges of only 6 ringgit. Because only for one night, 6 ringgit. Okay. If the charges for if the result for the blood count came already, my bill of 6 ringgit will have become plus 25 ringgit. So it was an order for blood count. So they count the number of tests. That is the difference between public and private. Private, anything that is ordered, they send it immediately to the billing. Billing will take and immediately enter to the patient's record. Okay, so that is the difference between public and private. System is more towards charity. Okay, so quality and mortality. Anybody has become pregnant before? Jana, Ainul, Norvina, pernah mengandung?
Once.
No, doctor. Not yet, doctor.
Okay. So for those who have become pregnant, you notice that the doctors, the nurses pay special attention to you all, especially if you're going to the government side, because the reporting system for the pregnant mothers is very thorough, very thorough. Why? Because if anything goes wrong with the pregnancy or the delivery, the person who handled the case will have to defend at 3 different levels. First level is at the district mortality meeting. Then they have to defend at the state mortality meeting. And finally, all these cases of maternal mortality will be brought to the headquarters, which is done twice a year. Okay, for this presentation. So in fact, for death, for maternal death, everything is checked, everything is counted. And they have extended this into the private sector. So if there are any maternal morbidity or mortality, the respective doctors or nurses, usually is the doctors lah, and they'll be called up all the way. When I was working in Rambau, I did not have ONG. For those who don't understand that, when I was doing my housemanship, my rotation does not include obstetric and gynecology. I started with medicine. After medicine, 3 months, I was sent to pediatric for 3 months, so 6 months. 6 months. Then I was for 3 months in surgery and 3 months in orthopedics, 6 months. So 1 year, I did not cover ONG. So nowadays, they have 2 years housemanship. So they will do obstetric, they will do gynecology, and they will do 6 months in the outpatient department. Either outpatient, 3 months in the outpatient, 3 months in emergency department. So nowadays, the houseman has got full rotation. They have got enough experience. So I was sent to Rambau. I did not have ONG. So since I did not have ONG and I know about this maternal mortality and maternal morbidity, whatever I cannot handle, I refer. Everything I refer. If it is risky, I'm worried about this patient delivering at home. I'm worried about complications that will cause trouble for my nurses. I will post the patient to the nearest hospital. So during my 1 year there, I had no maternal mortality or maternal morbidity. Alhamdulillah. The doctor who replaced me spent 7 years in OE. 7 years. So she was kicked out from because of the new policy that every doctor must do district rotation, must do health posting. Because she has done 7 years ONG, so she handled everything herself. Everything. She did not send a single one case to the hospital. And she had 1 maternal mortality. Very bad luck on her part. And she ended up having to defend at all different levels. She had to defend at the district twice. Then she had to defend at the state once. Then she had to defend at the federal level. So for your information, whenever we have a case of maternal mortality or morbidity, disciplinary action will be taken against the doctor treating the patient. It could be as low as a reprimand, static pay for 1 year or 2 years, depending on the recommendation of the board, or all the way until being removed from work. Fired. So there is a system for maternal part, which is very established to the extent every year, if there is a maternal death, the Minister of Health have complete details of every single one of the death. And we had Chua Yuming as the Minister of Health. He was presenting he was giving a speech on maternal mortality. He noticed that the data given by the Department of Statistics does not tally with the data that he has from the maternal mortality and morbidity. The rate of MMR, maternal mortality rate, reported by the Jabatan Statistik Negara is too low. They put it at 14 per 100,000 of deliveries. when the reality is about 44. So it's 40. So 14 versus 40. 14 versus 40. So the minister called up. I was there in that meeting. I know what happened. So the minister called up. Come this data something wrong. Turn out Jabatan Statistik Negara, the Department of Statistics, we don't know where they get their data, but somehow their number of deliveries is much higher. Okay, somehow the number of deliveries that they have is much higher, so compared to the number of mortalities that we have. So since the denominator is much higher, 3 times more than what we captured, that's why they end up with a much lower. We don't know why. We still don't know why. Maybe there are people who deliver in the jungle, not coming to see a doctor. They just register for IC. I don't know. I don't know. So that is the story for maternal mortality. So in terms of patient safety, yes. Okay, let's talk. But remember the story I told you 2 weeks ago about patients who change beds, and when the patient changed bed, one of them died. Remember when the asthma case and the heart case changed their beds, and when during walk round they end up getting the wrong medication, and one of them died. When that thing was, for every death that happened in a hospital, there will be a inquiry. And when the inquiry happen, they will look at the post-mortem report, and there will be a mortality meeting at the respective department. You have to understand, inside the department, you may have 4 or 5 experts. Okay, and it is by the district. There's a lot of people being involved. And there'll be people looking to pin the mistakes on the respective people involved. So there'll be a lot of checking to ensure that the death were not due to simple reasons, were not due to negligence, was not due to so they tend to have a good check and balance. So I'm talking about my own personal experience in Hospital Kuala Lumpur. Even for cases like leptospirosis, when this thing came up, there is a meeting, a discussion about cases like this, and trying to explain what happened. Simple things like malaria. If you have a malaria case and the patient died, that one will lead to your service record to have a bad remark. Okay, but there are things that should not happen. Things that are avoidable should not happen too. So that is for patient safety lah. So short, every level there's supposed to be. Is it ongoing in the private sector? Okay, it is ongoing. There is a mortality meeting at every department whenever there is an avoidable death. However, those in the private sector, the implication is not there lah. There is no way of penalizing these people unless there is gross negligence and the family take actions against the doctor and lead to the court case, or the family report to the MMC, Malaysian Medical Council. Okay, so every single one of the doctors, we need to have a license to practice. Get a license to practice. Sorry, just showing the attendance. To get a license to practice, we have to renew our license every year. Okay, and to renew our license every year, we have to make sure that we have received the necessary hours of training per year, and also silap. Okay, for doctors to be registered, can you see this website? Boleh?
Yes, doctor.
Alright, thank you. So let's search for my name, Tamel. Senang, easy. So let's search. So the name will come up, Azmi Muhammad Tamel. Bills. So this thing shows that I'm registered for the year 2023. I'm place of practice in UKM. Okay, medical doctor UKM. This is my registration date. My full registration. Okay, so this one, what's the meaning of 15th of August 1993? This is the date that I finished my housemanship and I received my full registration. For me to be registered, I must have no complaints of negligence, gross negligence, unnecessary death, or any wrongdoing. Example, selling MC or whatever. If there's any report like that, and I get reported, I will lose my license to practice. Nowadays, it is even tougher. Why is this tougher? Because I have to pay insurance. Okay, you know insurance? This one, they call it medical liability insurance. So for me, to be registered, I have to make sure I have insurance, medical negligence insurance paid. So, and the medical insurance that is being that we have to pay depend on the type of practice. If I'm an ONG specialist, my insurance is about 40,000, 50,000 a year. Okay. If I'm just a lecturer, medical lecturer, just teaching medicine, and I want to retain my license, my insurance is about 2,000 ringgit a year. So even though I'm not seeing cases, just to renew my license. So you can see that it is messy. It is messy. So there's always a check on the doctors to ensure that I can practice. So they even have my photograph at the system. Tanto. All right, sorry. I was supposed to show that. Okay. Let's get it out from here. Okay. So that is the story about medical license. So how about people, can they report against us? Yes. Go to mmc.gov.my. Lain lah jadi. I also don't know how this thing come out. mmc.gov.my. You can make report against her. Okay, so registration certificate, laws and regulations. If there's anything that you're not happy with you can go and check, submit, and you can give your supporting evidence, so on and so forth. Then if they investigate, there is valid reasons for your complaint, then they will ask you to come to the court meeting. There's a court meeting. I'm not bluffing. There's where there'll be your peers there to judge you. And worst part, you cannot have a lawyer. You have to defend yourself. Okay, and it'll be your word against the patient's word. So in terms of for the doctors in terms of practice, yes. Okay, there is a way of. How about the others? Helps the allied health. What do you call it? The supporting medical personnel, like pharmacists, like nurses, physiotherapists. All of you have got your own registration board, and there is a system whereby they will check on your uh, practice lah, and they will check on whether you've been getting your necessary training hours. All right. Okay. How about quality? Okay. There are KPI. There are indicators of quality. Okay. You can Google it up on the Ministry of Health on your website. And these KPI indicators, among them, I already mentioned to you, is MMR, maternal mortality rate. Okay. To ensure that there are no problems. I'm not going to go into full detail, but every single department have got their own KPI. Some of the more stringent ones are like for places like Department of Anesthesiology. Why? Because they take care of the ICU, intensive care unit. They monitor the death rate of patient based on type of disease, how many people died, how many percent, when they died, so on and so forth. So even for procedures, operation, there is an ongoing audit. Everything you got an audit. Last time, as a statistician, part of my time is spent helping the surgeons, the clinicians, analyze data of their audit. So they give me data of all their operation. I have to analyze and report accordingly whether they are doing okay or they're doing poorly. Nowadays, I'm still doing it, but the fine department. So that is how we ensure quality is achieved. Again, for private, I'm not so sure, but usually there is a unit quality, the quality unit that is involved in monitoring their respective KPI. KPI as in key performance indicator. In KKM, last time there was a unit, they call it TQM, Total Quality Management. I don't know what happened. When I was in the State Health Department, it was a big thing, the TQM. Nowadays, I don't know. Okay. Any questions related to patient safety and quality? Takut you're afraid that you go and somebody kill you. Possible? Okay, I'm not going to. Okay, I'm not trying to scare you. I'm not trying to scare you. I've been reading some of the journals. Okay. Remember the joke about the when you are in ICU, they noted that in the ICU people tend to die at 11 o'clock in the morning every day. It is usually the bed that is always the same bed, always the same bed that the patient dies. So they keep saying that the bed is jinxed. Anybody who use that bed will die. And the joke is people started to monitor the bed around 11 o'clock. What happened? Turned out the janitor come vacuum the floor, so they take off the ventilator plug and put in his vacuum plug, and patient is in the bed, end up dying of unable to breathe because the ventilator is switched off. I thought it was joke, so I look up the medical materials. In some textbooks, there are mentions of recorded cases where the patient reported of such incidents happening. Luckily, the patient was able to pull out the ventilator and breathe on her own because of these incidents where people switch off the plug for their ventilator. Alright? So usually when things like that happen, the medical audit should pick it up lah. But if you look into the Netflix nowadays, I think that's where the question come from. Right? The Netflix, the story about the nurse who kills people, her patients. The other one was about the doctor who killed his patient. The Netflix. All right. Anything else you want to ask before